Hello, and welcome to Physician Spotlights. I am your host, Dr. J. Patel. Physician Spotlights is a forum to learn more about our outstanding physicians in the field of nutrition and discuss important topics and ideas. With the help of ASPEN, we are bringing these videos to you. Our guest today is Dr. Todd Rice. Dr. Rice is an associate professor of medicine in the division of Allergy, Pulmonary, and Critical Care Medicine at Vanderbilt University in Nashville, Tennessee. With over 20 years of clinical and research experience, Dr. Rice has made numerous contributions to advance nutrition research and enhance clinical care. He is the president of ASPEN, and I am honored and thrilled to be able to interview him here today. Dr. Rice, thank you for joining us today.
Yeah, thanks for having me.
Dr. Rice, can you share with us how you got started in clinical nutrition? Or in other words, what was it about clinical nutrition that caught your attention?
Yeah, so I was a fellow in pulmonary critical care here at Vanderbilt and trying to find a clinical project to do. And there were a number of clinical projects that I was interested in, but one of the ones that I was interested in that sort of caught my attention was what to do with nutrition in the critically ill patient. We had some very small studies and some minimal data, but overall we really didn't have any great data that guided us to what we were going to do. And so I knew that that was an area that we needed more data, and we needed to better understand how to deliver care to help our patients. And it was also an area that my mentor encouraged me because he said, there's the world is yours in this area. There's not a lot that's known. There's a ton of questions that you can answer. You can make it into a career. It won't be one study and then everything's known and you'll be done. You'll be able to add a study after a study after a study onto that. And you can make a career out of it, and that was sort of the appeal, was an area that we didn't really know a lot of answers to, and an opportunity to provide those answers and better the care for our patients, and then also a number of questions that could be answered that would result in a long investigative career in an area like clinical nutrition.
Yeah, with the breadth of information that was available at the time, how did you decide on a particular question, and what impact did mentorship have on you to help you decide on that particular question?
Yeah, mentorship's obviously huge and is a big part of being a success in research. We have some of the hardest working people that go into research, and they want to do good stuff. And sometimes just a little bit of guidance or a lot of guidance from a mentor who's done it before and can guide you really focuses that energy and gets stuff done. So my mentor was not a mentor in nutrition. And what my mentor did for me was said, I'm not that person. I can mentor you in trial design and in doing studies, but let's find a critical care nutrition person to be your mentor. And what we did was, Gordon Jensen was at Vanderbilt at the time. He was actually ASPEN president when I was in part of my studies. And we reached out to him, and he agreed to be kind of a co-mentor and help. And then my mentor also said, you need some other people that you can interact with. So this is the first time that I met Steve McClave, was my mentor reaching out and saying, hey, Steve, we'd like you to come down. We want to run a project past you. We want your honest, open thoughts. And while you're down here, we'll have you give a talk to the division and sort of have this interaction. And so that's how I kind of got mentorship in nutrition.
That's wonderful.
The area, what topic were you going to study was navigating a terrain of, I was a fellow, so it had to be a topic that was reasonable for a fellow to do. It had to be a topic that we thought was clinically important, and feasibility. If you pick something that's not feasible at all, it's the fastest way to failure, because you can try as hard as you can. It's never going to be a success. When you don't have successes, you get discouraged and you think of other things and you go different routes. So that's how we ended up. Many know that the first study that I did was actually a local study of trophic versus full feeding that sort of set up the pilot data for the ARDS network study trial. We actually wanted to do no feeding versus full feeding, but we were afraid that we couldn't get people to consent and couldn't get people to participate in that study. And so we did trophic versus full feeding as the first trial.
Can you share with us a little bit of what you learned from some of that early work, which then you implemented into some of your later work, or even now? and what
Yeah.
advice you would offer, junior faculty, starting early, what things you could potentially help them with at this point.
Well, I think there's a number of things that experience taught me. Some of them critical care nutrition focused. So I learned a lot about what people were doing with residual volumes and what people even define trophic feeding as, and the logistical problems in trying to deliver a full feeding arm. And I learned during that time that our nursing colleagues are taught in nursing school that gastric residual volumes is the most important thing that you can do for safe administration of enteral nutrition, and that you absolutely have to check them, and just learn some attitudes. And I learned things about like how the pump measured what was delivered and what happened when feeds were held, and how that was documented in a medical record, and lots of logistics. I learned a lot of clinical trial stuff too. I love telling this story. The very first patient that we enrolled was randomized into the trophic arm, and the next day we show up on rounds and the patient has hyperkalemia, potassium's 5.5 or something like that. My mentor happens to be the faculty attending on rounds that day. I'm the fellow. It's our project. And my mentor, who's the attending, says to the team, well, why do you think this patient has hyperkalemia? And every single person on the team said, it must be the nutrition study. And I learned quickly that day that if a patient's on a study, everybody blames the study for absolutely everything that goes wrong. We sat there for 15 minutes, and my mentor challenged me to brainstorm about how trophic feeds could cause hyperkalemia, right? Which if after 15 minutes I couldn't come up with a reasonable mechanism as to why it would do that. But I learned that day that the study's going to get blamed for everything, and you just have to be used to that and have to kind of take this laid back approach of, okay, we'll investigate, we'll think about it, but we think it's unlikely. So it's stuff like that you learn from experience.
Oh, and that's wonderful. I think that, wisdom will go a long ways for people who are going to listen to this interview. Can you talk to us a little bit about how your research focus has shifted over the years? And then maybe as a follow-up to that, what kind of questions should we be asking as we move forward as an organization?
Yeah. So first about the research focus shifting. So, I went into critical care and did critical care because I thought I wanted to do clinical trials in the ICU. And many people, my parents included, don't really understand what I do. And my lab is the ICU. So I don't have a lab with animals. I don't have ELISAs. I don't have biochemistry. My lab is doing experiments, conducting trials in critically ill patients. And the ultimate goal is to try and improve the care of critically ill patients. And one of my mentors, as I was kind of becoming a fellow and doing this, said to me at one point, he said, the best part about doing clinical research in the ICU is that you don't get to improve the care of a single patient like you do as a clinician, but that you actually get answers and you get to improve the care of all the patients, or hundreds of patients, or thousands of patients, or millions of patients. And I think that's true. I think answering these questions, hopefully changes the care of patients, even patients that I don't know, and patients that are outside of my clinical care. And, that's something I think about a lot, and something that is been very prominent in my thought process as to how I do studies, why I do studies, and why I continue to do this. In that, it was a little bit of a transition for me, because I initially started doing true efficacy trials. Does this intervention work? And then I realized that the question I really want to answer is, does this intervention work in clinical practice, in regular practice, not in this tight environment of an efficacy trial, of rigorous inclusion-exclusion criteria, a randomized controlled trial, for example. But I want to know if it works in practice. And so, Jay, you and I have talked some, and you probably know this and may have even led to this question, that I've sort of moved my research focus into pragmatic trials, and pragmatic trials in a large, very heterogeneous population of patients, to try and understand what we should be doing for the masses to improve outcomes. The EFFORT trial, which is a higher versus lower protein target trial for nutrition, is set up that way. The goal is to try and include as many people as we can, not to have large exclusions and have a perfectly set up trial population, but to include as many critically ill patients as we can, different types, and to get an understanding of what's the best thing for the mass of our patients, for the majority of our patients. I've done that both within the critical care nutrition world and I do a lot of ICU research outside of nutrition in the critical care world. And all of my research stuff has moved more towards this pragmatic nature to try and better understand effectiveness and how the actual effect of an intervention in real life practice as opposed to in a tightly controlled research environment.
That's wonderful. Before we wrap up here, my last question for you is, as president, how do you align your professional and personal goals with the goals of the organization, and maybe even the context of pragmatic trials?
Yeah, so the next year will be interesting to see kind of how the presidency plays out. I'm excited about it. I'm very enthusiastic about trying to advance ASPEN's mission. And there are many things that ASPEN has in their strategic goals that I think are the wave of the future and the way that nutrition care has to be done. It needs to be done in a way that's more universally reaching, that's more pragmatic, but it also has to be done with sound science. And one of the problems that we've, as you know, as we've encountered in the nutrition world is that we have reasonably good basic science, and then we've had less robust clinical science. And increasing the robustness of that clinical science so that we have really good evidence and we know this is the right thing to do and we should do it, I think is a pillar that we have to continue. And ASPEN's done a great job of making that one of its initiatives, its strategic initiatives, and I think we have to continue to push that. And then the other ASPEN area that I'm really excited about is international collaboration. There are many other nutrition societies, international nutrition societies, that are doing great work, that have similar missions and goals as ASPEN. And instead of, maybe in the past we thought of those as being competitors of ours, but instead of taking that mentality, I think a collaborative nature is the way that we can truly advance nutrition science and the nutritional care of our patients to the best of our abilities. The good thing for me is that those strategic initiatives from ASPEN align with my career goals and my personal goals pretty well. As kind of you heard me talk about my research goals, my research goal, it really is to get knowledge and improve the care of all of the critically ill patients, not just necessarily the ones I take care of. And that overlaps with ASPEN's goal of improving the nutritional care of all patients, not even just critically ill patients, pretty well. So fortunately, those are aligned pretty well, and I think I can kind of carry the path to both of those at the same time.
That's wonderful. Those are awesome aspirations, and ASPEN is fortunate to have you as president, and we look forward to hearing more about your work and your goals in the year ahead. At this point, I would like to thank Dr. Rice for joining us. I would also like to thank ASPEN for their partnership for this forum. Thank you for joining us today. No matter where you are, have a wonderful day or night. Thank you.
Thanks, Jared.